Hello and welcome to Clock Talk with Dr. Greg Brannon. Today we're going to talk about prostate cancer, which is probably on the mind of every single male once they turn 35 and older. Every day they think about it. Because, males, they can't have anything wrong with them, below the waist.
And they all do.
So let's talk about prostate cancer, the A, B's, and C's of it, and we'll go from there.
All of us will die with prostate cancer, bottom line. But dying with it or of it are two different things, right? So this is important to understand. The prostate is a very, very active organ. The analogous organ in a woman would be the uterus, okay? When we're inside the womb developing, that's how they differentiate by the hormones. And our, obviously genetics lead to the phenotype. Gene is the DNA, the phenotype is how it's expressed. So in our field at Optimal Bio.
Okay, let me back up.
Mm-hmm.
Just tell us what the prostate gland actually does.
Okay. The urethra goes through it, and it actually adds fluid and chemicals to the semen, is what it does. And it makes that healthy. And you need it healthy to have reproduction, period. And it sits in the base of the penis, and again, the urethra goes through it. I'm reading a great book on prostate cancer. A little later, I'll go over that in a moment on the hormones aspect of it. But let's think about this. We hear in our field, Optimal Bio, in testosterone therapy treatment. Testosterone therapy causes prostate cancer to grow. Period. End of story. It's verbatim. Everybody knows it. Dr. Morgenthaler at Harvard wrote a great book called Testosterone for Life. He's a world expert urologist whose specialty is prostate cancer. And by the way, hormone pellets. So in his book, he tells the whole story. He read that paper. It's a famous paper by Dr. Huggins and Hodges at the University of Chicago in 1941. He knew the paper backwards and forwards, and he goes, I'm going to go read it myself. He went and got it out of the library. Great. He tells a great little story in there. The original Huggins and Hodges studies were on dogs first, which obviously makes sense, doing animals. But the famous everybody quotes was a famous study with how many people in the study that said testosterone therapy causes prostate cancer to grow. 3 men, and 2 were disqualified. 1 man study, and he already was castrated. So he had no testosterone. That's the famous paper study goes.
How can science allow that?
Well, because Dr. Huggins won the Nobel Prize in 1962, so he's obviously brilliant. I'm not saying that, but it is one study. And again, so now there's so much current stuff now. I mean, flash forward. Dr. Morgenthaler's papers, his book is great, but his papers are fantastic too. He finds that this prostate gland itself gets saturated around 99 grams per deciliter. So anything above 90 can't make it grow. He did a study with only 13 men, but this is interesting.
Okay, hold on. What does that mean?
So the prostate cancer.
Like you're jumping ahead of me on this stuff because I wanted to know what the prostate actually does. You gave me one thing.
Well, it's basically all it does. It supports the genital urinary system. It gives fluid for the semen. You need it healthy when it gets inflamed.
So if it gets removed, you cannot reproduce.
It decreases the amount. Yes, it decreases the semen, and therefore the semen, the sperm matures at a lower temperature and needs that fluid to mature. Yes. So the bottom line is you're not going to have a baby.
All right. Okay. What about erectile dysfunction if it gets removed?
That's the problem. It's all the nerves in that area. The penis has 2 functions, right? You have to urinate and for reproduction. So if those nerves get involved in the surgery itself, yes, you can have ED problems, 100%. There's a great book, flash forward, called The Prostate PSA Hoax by Dr. Thomas Albin. I recommend we read that book. Thomas Albin, who's he? He invented the test to isolate PSA.
Right, we'll talk about that in a few minutes.
Okay, so back to our stuff.
So back to your stuff now. So I just wanted to understand what the prostate actually does.
So that's why I say in a woman, it's a function for the genital urinary system for reproduction, just like the uterus in women. Okay, so it needs testosterone to be healthy. And so he did another study. He had 13 men in his study who have documented prostate cancer that he personally biopsied. Then he gave him pellets, testosterone pellets. He came back 2.5 years later and rebiopsied them. 56% had no prostate cancer, 40% no change. Then he has also multiple papers showing men with prostate cancer treated with testosterone pellets versus those who aren't. Those who are treated with testosterone pellets live longer, less heart attack, dementia, cardiovascular disease, because that's what testosterone does. I said in some other clock talks, we talked about there's been studies that show men, the standard care with prostate cancer is androgen deprivation therapy. So turn off all your testosterone. And they find those men have more dementia, more Alzheimer's, more cardiovascular disease, and more osteoporosis. And some studies show those who treat when cancer reoccurs, it's a faster mortality.
So what's the reason why they would turn off the hormones?
Okay, I'm not a urologist. I'm not an oncologist, but I study a lot of this stuff. It's because in theory, the prostate gland needs testosterone to grow. Back to Dr.
You're shrinking it back.
Dr. Huggins' paper, right? So that's the problem. There's only one person who's a study. And Morgenthal's literature, he revolutionized it. Mayo Clinic in 2001, their clinical book called The Proceedings, 2001 Proceedings says, testosterone therapy does not increase prostate cancer or benign hypertrophy. Okay, that's Mayo Clinic. Morgenthau in his book says testosterone therapy now or has never been proven to increase any prostate cancer or benign hypertrophy. In fact, it's just, I'm not saying it's a wives' tale, but that it sort of is. And that's the problem, is because when you lose testosterone, you lose vitality, depression, anxiety comes, mood swing, all these things happen with low testosterone. So therefore, Dr. Friedman has a great book, came out in 2013. The receptor of the prostate, testosterone converts to estrogen, and the prostate does not have that enzyme. But as you age and some defects, it does. And there's two receptors, an alpha and a beta receptor. It may be more estrogen dependent, causing the prostate, not the testosterone. In fact, he has studies showing high dose of testosterone actually reversing it, sort of actually mimicking what Dr. Morgenthal's paper did.
So with the increase in prostate cancer nationwide and worldwide, is that because we're living longer, or is that because we have these hormone disruptors that are in our diets and in our environment?
Which is great. We don't have a placebo group. You know, all of us eat the same food. How much antibiotics, hormone-driven food, our milk, all these things have been, all these synthetic things over time, the plastics, the xenoestrogens, it's so multifactorial. But when you look back at the biochemistry, testosterone makes the prostate healthy. And think about it logically. When's your highest testosterone should be? 18, 25? How many prostate cancers at 18 and 25? None.
Right.
So maybe we'll do a clock talk on actual receptors of the prostate. Friedman's book is fantastic. It talks about alpha and beta, progesterone A and B. The big thing here, Jim, is we know when cells are messed up, they make a thing called BCL. And when that thing's turned on, that increases inflammation and growth. So what you want to do is turn those things off. And testosterone appears to turn that off. And there's two receptors for testosterone too. There's a membrane receptor and a nuclear receptor. The membrane receptor may be a problem, but not the nuclear receptor. So I guess I may draw pictures one day and show some complication there, but it's just not black and white. A hormone that in the womb causes the prostate to develop, the hormone that causes it to mature, the hormone that causes it to do its function suddenly causes it to become cancerous. That's sort of the issue, man. So I mean, I guess I can't stress Morgenthal's research. That book is phenomenal. And then those research geeks go to his actual papers. It's phenomenal.
Now, I know you're not an oncologist, but are we over-treating prostate cancer? Because you started out by saying that all of us will die from prostate cancer.
Die with it.
With it, or
not of it.
Not of it. Okay.
It isn't.
So what do you mean by that?
Because the cell age, mitotic cells are going to grow. Our immune system gets weaker over time. So that's just a phrase. That's a phrase that he has. Thomas Allen talks about in his book. So the question is, are we having too many biopsies based upon a PSA test? PSA, this is a standard in America. Over 4.0, see a urologist. We recommend it all the time. A rapid velocity change of 1.5 per year. Just go see a urologist. But multiple things can make it go up before you get your test. Being intimate for 2 days prior to that, riding a motorcycle, an infection, being anything puts pressure. A truck driver down a long distance. So there's reasons to make sure the prostate is not inflamed. That's causing the increase, because PSA is not, it's prostate specific antigen. It's a protein in the prostate, is not specific for cancer. A large man with a large prostate, just because he's large, it's based on volume. But again, there's multiple people showing that testosterone therapy does not increase volume, does not increase PSA. Maybe a transient rise becomes healthy, but has never been shown to be that way.
So I had a physical 3 years ago, and they got time. I was all nervous because I'm waiting for the fun rectal exam. And she goes, "You're done." And I said, "Aren't you going to examine me?" And she said, "Well, we got your labs and we're going to look at the PSA."
Right.
And she goes, "Whether I examine you or not makes no difference to me, because if I examine you and your prostate feels normal, but your PSA level's high, I'm referring you. If your PSA is normal but your prostate is lumpy and hard and like a walnut or whatever, you're going to be fine. Should I be concerned?
The standard of care has changed.
So basically, they were saying, "Hey, it's the PSA, PSA." And
I was a pelvic surgeon, and I was trained to always feel before you cut, right? So, but I know that's the standard of care now. But I have some great urologist friends here that their fingers are very, very sensitive, and they can't pick up nodules. The primary care may have enough. So I think what she's doing is correct in the standard. We're one of the few countries that actually use PSA as the only test. I think Canada stopped using it again. This is Greg's opinion, not a urologist, not an oncologist, is educate. But Dr. Thomas Albin's book, the guy who invented the actual test to isolate the protein, actually says it's not used for that. And I really want people to read that book and study it because it is, every man talks about this, right? I agree 100%. But there's so many reasons why it goes trans and goes rise. But again, Morgenthal's paper showed men with prostate cancer who are treated, again, after treatment. In our protocol is when a urologist clears our patients with prostate cancer, then they come to us because we're not going to we're going to do standard of care. But they come back, they go back at home, they feel their brains back, their intimacy's back, their overall vitality's back. But on pure mortality, cardiovascular disease decreases when you're back on testosterone, dementia, all these things are beneficial. Again, you have multiple studies showing men deprived testosterone, the 4 major symptoms are dementia, Alzheimer's, cardiovascular disease, and osteoporosis. When you go back on those things decrease. It's because that's, again, I understand correlation, causation, but it appears to be, I'm trying to get our hormone levels as youthful as possible because there are no papers showing a youthful hormone. And this is the thing, a youthful hormone level is not beneficial. And this is the question, Jim, this is a big one. But Greg, it's super physiological. Well, really, which range, which decade? If a range was 800 to say 1360 years ago, and remember what a range is it's a standard deviation. They get 10,000 people, they plot a point, they get the median, standard deviation, it's a bell curve. That means 10% are higher, 10% are lower. And the curve has moved from when I was in school, roughly 800 to 1300. Now it's down 248 to 916. Why does it move? Is the question. Why did it move? So when I go, if our levels say 1100, well, that's super physiological. Well, it wasn't 40 years ago. I agree. When you get to a point of 3,000, make a number up. Yeah, I see there's no benefit. But interesting with testosterone, it's linear. The higher it goes, you get benefit, but how you eliminate it is it converts to estrogen and then you pee out. So you can't really build up extra that way. So I don't like that they move the goalpost on me, Jim. That's what I don't like. And the cancer, so think about it. So as the range has decreased, meaning lower testosterone, prostate cancer has increased. Let that sink in. As the range has changed, the prostate cancer has increased.
Have they changed the ranges on the PSA test?
No, it's been 4 forever. Which again, you need to cut off somewhere, and you look at the data. If I remember correctly, men over 60, not you, me.
It's because I'm not 60 yet.
I got it. Okay, I'm just
Hopefully I don't look it.
Okay, you're optimal bio. But about 15% of men with normal PSAs got prostate cancer. Does that mean you start biopsy everybody that has normal PSA? No. So that's why it's so important that we understand why we biopsy what we do, and I'm not anti that. I just want the best. We're very believing that the foundational principle of medicine is informed consent. When patients leave here, we give them books to read, articles to read, both sides. It's their body. We just want to be on the journey to help them out. We're here to sell nothing. We just hope that we understand to give them that. Sometimes not being trained in something, actually have a clearer view on that. And that's what I want to make sure everybody gets the data because, again, it's their prostate.
And for our situation, our protocol, you had mentioned earlier about the PSA increasing by 1.5 in a year. And we just simply refer over to urologists and what have you. And,
yep.
And then once they clear, they come
back. Once they clear. Yep. We want to be collaborative with their doctors. And we're very fortunate. I know doctors I know here have operated for years with that are brilliant surgeons and they're state-of-the-art stuff on this. So we try to we want to be part of a team. We're not no demigods here.
Interesting stuff as always. I do think, to your point earlier, I mean, I know some people that have gone through treatments and, they have lost a significant amount of bone and muscle and
the heart.
Yeah.
What kills us? Heart disease. What can we do to push the heart disease out? That's why it's important to put data, put percentage, put numbers.